Hi, everyone. Welcome to the fourth, I think, in our series on HIA How To. This, uh, this session is on designing the assessment phase. I'm Sandra Whitehead. I am currently the president of SOPHIA. It's my honor to welcome you all here. And I see some members of our steering committee have joined us. Welcome to Jimmy Dills and to Gabrielle Gasway. We're so glad to have you all here. So this webinar is being put on by SOPHIA, which is the Association of Individuals and Organizations that really we're supporting excellence in the field of health and all policies and health impact assessment. And we create resources and provide webinars and peer mentoring. And we have a newsletter that communicates timely information on resources, training, and TA around HIA and health and all policies. And you can join SOPHIA for a very low price of $50 at hiasociety.org. So we hope that if you like this webinar, that you will join SOPHIA and become a paying member. My day job is that I am a professor of sustainable urban planning at George Washington University. And if you're interested in the connections between health and the built environment, my students have a student-run podcast that you can tune into. So just some basics about HIA before we dive into the assessment phase. HIA is really this very flexible 5 or 6 phase process, depending on what literature you read. Here at SOPHIA, we subscribe to the 6 phase processes, and we say phases instead of steps because we think that these phases are iterative. You're going to be finished with scoping, but you're going to look at the assumptions you made in scoping throughout the process. And that's just one example of the recursive nature of HIA. And HIA is different from other assessments in that it highlights impacts that disproportionately affect different groups and makes recommendations. A lot of assessments will just assess and give information. HIA makes recommendations to maximize positive health benefits and minimize risk and harm. So as I said, this is our 4th webinar. We did one on, maybe it's our 3rd one. We did one on HIA overview. We did screening and scoping. So it is the 3rd one, it's assessment. And our next one in August will be around reporting. So what is assessment? Assessment is the phase of the HIA where you are mobilizing data and evidence to characterize the baseline health conditions that you'll need to predict changes and impacts, right? If you don't know where you're starting from, it's very hard to predict change. And then it also is used to characterize, to predict and characterize impacts of the decision under review and to evaluate uncertainty and to think about how we address that uncertainty. And I'll talk a lot about that in just a few minutes. So the first thing you do in the assessment phase really is to think about your existing conditions. And so you want to look at the relevant population health status and health determinants within the community, because you've already identified your geographic and your demographic and your temporal parameters back in your scoping. So now you're taking those parameters and you're looking and drilling down to this particular populations of interest, whether that is everyone who lives within the area that's impacted, or whether you're just looking at populations who will be disproportionately impacted. And that's a decision you can make as you get into your scoping with your community group. So existing conditions should also look at barriers to health and well-being, including evidence of poor health status among the populations and how they got that way, right? It should really be your conditions on the ground. You've defined your geography, you've defined your demography and your time frame. So what does it look like before the decision? And then from these baseline characteristics, you can make your predictions of benefit and harm, and to whom benefit and harm will be accrued, right? It's that sort of beginning phase where you start with most public policy decisions of looking at who benefits and who is impacted. So in describing existing benefits or existing burdens of the community, you can and should include historical and structural stressors. And what I mean by that is looking at the background of the community. Has this community been traditionally marginalized? Has this community is it already experiencing environmental injustices? And there are a number of really great tools. There's many states now have an environmental justice mapping capability. I know that New Jersey and Minnesota and California have their own, but you can also use national tools to define these communities. If you're looking at See First or the White House environmental justice tools, mapping tools. And these can really give you a starting place for defining community burden and looking at historical and structural stressors, things like racism and redlining, things that really made this community how it is, the contributing underlying factors for how this community got this way. But also looking at what are the environmental levers that are currently impacting health and well-being. And I'm using environmental in the larger socio-environmental context, right? Not just environmental, looking at what we normally think of as the immediate environmental things. I'm talking about also economic conditions, social conditions, things like, was there a project back in the 70s that separated this community geographically? All of these things contribute to the existing conditions and can give you a richer, more robust HIA product. And you also want to make sure that you're looking at the political and policy environment, right? Not just the physical environment. And by that, I mean other policies that would impact or magnify some of the impacts. And what are the political realities of having these impacts addressed? Not that you shouldn't address impacts that don't have a way of being addressed politically, but being aware as you frame your analysis of what those pitfalls are and how to advocate with your community. Sources and evidence. Evidence used in the assessment phase can come from a wide variety of sources and will vary based on the context in which the HIA is occurring and on available resources, right? If you are doing a comprehensive and you have a lot of funding, you'll be able to look at a lot more data sets and a lot more different stressors on the community than you would if you are doing a rapid and you are trying to look at what are the most important things that need to be addressed. So the kinds of evidence and the way that you pull it will vary. The sources that normally researchers who are doing HIAs use are existing literature and data. One of the really great sources of existing impact data is not just to be found in the peer-reviewed literature, although that is certainly a great place to start, but looking also at other HIAs and looking at other empirical research and studies, tapping into professional expertise and local knowledge. And I'll talk a little bit more about local knowledge in a minute, but making sure that you have the expert implementers, the people who are going to be implementing the decision, have input, and also the people who are going to be impacted by that decision. And making sure that you have the ability as you're setting up your assessment to provide weights to those different kinds of data, and being sure that you've identified whether or not the data you need exists already, and if you need to collect it in a way from stakeholders. Making sure that you are including the community voice in all phases of the HIA is really important, but I find it to be especially so in the assessment phase. You don't want the community to feel like you're doing things to them, but that you're doing things with them. You want to be able to have their input at every stage of the decision-making process, so that you're being transparent with them, number one. And number two, that you're identifying the things that are most important. So the community, like, we don't live there as the HIA practitioner. You might, but historically, you probably don't live in the community that you're looking at. So making sure that you're including community voice and that you're addressing issues that don't necessarily show up in the data that you've collected from other HIAs or from peer-reviewed studies, right? Making sure that the community's voice is heard, things that they feel, that they know, that we can't always quantify from a study that isn't particularly about that neighborhood.
Mm-hmm.
And making sure that you're including the community in identifying any equity issues, and that they are ground truthing your findings as you work with them to co-create recommendations. So making sure that you are including them, but that because they are your advocates for the solutions that come out of your HIA. And if you have the community on your side, if you are working with them throughout, then they are going to be the best people to present your recommendations to the decision makers. But really, what you want to be conscious about is that in the assessment phase, this is where we are taking data, information, and knowledge and turning this into how we are informing our recommendations, how we are marshaling this data, both the baseline data and the prediction data, to tie to evidence-based recommendations. One of the true values of HIA is the use of best available data. So I'm going to talk about what that means. Using different types and methods of data and data collection will give you methods to not just triangulate meaning, but also to validate and ground proof your data that you find. It will give you the opportunity to center populations who are impacted by the proposal, to center their input, their thoughts, and their community research, their traditional ecological knowledge, their environmental knowledge that they have into the process, which also lends it legitimacy. Just because you don't have 4 double-blind studies that say this is an association between this decision and this particular health impact doesn't mean that you cannot use those health impacts. You can say, you know, the data isn't all there, or just because the data isn't all there in the literature doesn't make it an invalid piece of evidence, right? Making sure that we are using all kinds of data, not just quantitative and qualitative, but looking at professional expertise, lived experience, and local knowledge, and giving those the same weight that we give maybe a scientific toxicological study. Because these are also evidence that will inform what's right for that community, what recommendations will ring true, which are valid, and which will be acceptable. In summarizing in thinking about using your data sources, you want to make sure that whenever you create that pathways diagram we talked about in the screening and scoping session, when you have your pathway diagram and you're starting to look at the evidence that connects the intervention to the health outcome, you should rate your strength of evidence, right, based on best practices for the relevant field, whether that's a meta-analysis, a qualitative method, or an epidemiological study. It's very important to say these things are very strongly defined in the literature. These things are emerging, and these are things that haven't really been defined well in the literature, or takes 20 years, like obesity, for instance, to manifest. But we know, based on our community knowledge and other things that are going on, these are happening. And so making sure that you're talking about the strength and the quality of your evidence, and that you are acknowledging, right, where evidence might be insufficient or not quite there to evaluate a potential health impact. And you might discard those impacts, or you might give them less weight in your study. So people ask me all the time, well, that's great. We've got this qualitative data. We've looked at health outcomes. We know the health status of the community. And we have this quantitative data, and say air quality data, that we want to use to predict impacts. How do we make that talk to our qualitative data? Right. And so there's a bunch of different ways to think about this, but I think that the terminology feels out of touch, mixed methods, but all it really means is, how do we use quantitative and qualitative information to give us the best possible outcome, right? Whenever you're just looking at quantitative data, it feels like you're leaving out the people part, right? The part that's most important in an HIA. And when you're just looking at qualitative data, that feels a little squishy to people who are science-based, right? Like most of us who are HIA practitioners. So how do you think about not just blending those two things, but using qualitative and quantitative data in a complementary fashion? So there's a few approaches of how you would use mixed methods data. And thinking about the first one is really to inform equal consideration of qualitative and quantitative. I talked about balancing those two things. That's really what I mean by informing equal consideration, making sure that you're not just looking at one at the expense of the other. And mixed methods approaches can also inform the integration of community narrative, right? Not just we did a survey and people told us what they thought or how they felt about the safety in this new street that's been proposed, but also that we are using both the, say, it is in a street reform, the actual safety, what the data tells us about crashes and injuries and fatalities. And also we're integrating that with, how do people feel in that space? Do they feel safe? Do they feel like there's enough light? Do they feel like there's enough police presence or community eyes on the street for them to feel comfortable there? That's what I'm talking about, informing the integration of community narrative. And then mixed methods are really great for interdisciplinary work, right? Like HIA, I think of as the ultimate in interdisciplinary work, where you bring researchers and experts from different fields together, and you form this picture of the impacts of this particular policy plan or program. It helps us to be pragmatic in our work, to make sure that we are looking at all sides of it, we're not leaving things out, and to build a more comprehensive understanding of what the impacts are. So it's really building this matrix, if you will, of bringing together different kinds of evidence and using them in a complementary fashion to really compensate for the weaknesses in one that is in the other. I'll show you what I mean a little bit later. So there's a few ways to integrate qualitative and quantitative data. The first is data transformation, where you are taking community narrative, and I'm going to do this from the qualitative aspect because I think it's a little easier for social scientists like me to understand. So in data transformation, you're really taking this qualitative information and you're using something like maybe content analysis to code those conversations, right? You're using word frequency, themes, or word counts, and you're coding the narrative into categories that will fit in with your quantitative data. The second way that I've seen this done, and I've done this myself, is using a narrative to talk about the qualitative and the quantitative side by side and to integrate those through your writing, not necessarily through charts and graphs, but in your discussion of impacts and talking about the real value of integrating these and why it's necessary to have both. Side-by-side results. I've seen this primarily when HIAs have been done by maybe toxicologists or epidemiologists, folks who are from the sort of right brain side of the public health sphere, and really wanting to look at what you found from the quantitative right next to what the community said, and trying to reconcile those, right? And then my favorite way is really the joint displays, using this data to drive a visualization, maybe an infographic or even a detailed logic model that you can share with the community so that they can see how the data fits together, the qualitative and the quantitative. And if you're interested in these kinds of ways of integration, I highly recommend the article that I cited here from 2013. So different methods of integrating the qualitative and the quantitative. I took this from mixedmethods.org, and my research partner, Dr. Christy Ellickson, has a whole presentation on this. And really what you're doing in the convergent method is you're bringing the qualitative and the quantitative together, and you're merging them sort of that either in a side-by-side or in a narrative fashion to create that interpretation of the impacts. You're saying we found these things in the toxicological profile. Maybe these are how the chemicals are interacting in the atmosphere. This is how we know that people inhale PM 2.5 at these rates, and these kinds of folks are more susceptible, you know, children, elders, people with underlying conditions like myself. And then we're putting that next to the qualitative, and we're saying, this is how people feel about this. This is how they're experiencing what we learned from this data. And you're using those two things together to create an impact statement, to understand how the community is truly impacted. So that's the convergent method, where you do these two analyses separately and then you integrate them, you merge that data. Explanatory sequential is where you're looking at the quantitative data, and it is, in turn, you use the qualitative data to explain what you found. So we looked at 14 studies that found that these kinds of air pollution impact children disproportionately, and this particular use is going to produce this kind of air pollution. So you take that quantitative data analysis and you would use that to explain why you're looking at children, why you're looking at elders, why you're looking at people who already have asthma, and doing that kind of as an interpretation. And then there's exploratory, like this is explanatory, right? What I just talked about. Exploratory is where you talk to the community before you do your quantitative data collection and analysis, and you ask them, what do you think the issues are, right? There's going to be this recycling plant application, and we really want to know how you feel about this, what you think the impacts are going to be. How do you think your community is going to be impacted? And you use that to drive what you look at in your quantitative analysis. So you use the qualitative, the community input to drive your decisions around what qualitative data to look at and analyze to reach your interpretation or your statement of impacts. You want to make sure, and this is so important in the assessment phase, that you are describing your limitations, right? You should always describe the uncertainty in your predictions, whether that uncertainty stems from, not having enough qualitative or quantitative case studies, not having enough preponderant, what we call in public health, the preponderance of the evidence, and I'm using air quotes, that really says, there are 18 double-blind studies that found this, and so we know this to be true. You almost never have that in public health. And so making sure that you are caveating the data that you're using, the evidence that you're using to drive your conclusions, and you're just explaining what you used, why you used it this way, that you gut check this with the community, and making sure that you're talking about your assumptions and your inferences in your modeling or in your prediction, and just being very, very clear about that. This is also where you want to be sure that you're noting your justification for selecting or excluding particular methodologies or data sources. And sometimes you just can't, right? Like, you can't survey every single household in this neighborhood, or you can't, survey them 5 times during the study period. You have to just say, we have enough time, or we have enough resources to do this at this point in time, and this is the most important. So just explaining your decisions and how you got there in your HIA will not just create transparency with the community and the decision makers, but it also gives you that level of defensibility. I hear a lot of people say to me, especially people from the more, in air quotes, sciencey side of this, right? Like, oh, well, all you people in HIA want to talk about is, what does the community think? Well, we need hard evidence because we've got to defend this in court. Community narrative can be defended in court, just like quantitative data. You just need to be very clear about how you collected it, what your limitations were, and what you found, right? This is so important to understand, that we're not just saying, well, these are the things the community said, or, we don't have any way of proving those. These methods of integrating that I talked about, integrating the qualitative and the quantitative, this is how we validate our use of community narrative. This is how we're integrating that into HIA. And if we as HIA practitioners are very clear about this, and we are very conscious about how we're doing this, then we will gain more acceptability for this being defensible in court, because I believe that it is, and HIAs have been used in court. Making sure in your limitations section that you're also acknowledging when applicable methods were not used. Maybe there's a modeling technique that you could have used or that exists. Maybe it's too expensive. Maybe there's not air quality data, for example, for this particular neighborhood. It only exists citywide, or you can't drill down to a census tract with air quality data. Just say that, right, in your HIA, or say how you extrapolated that citywide data down to your census tract, and just being very clear about it. right? And you can say things like, well, you know, we couldn't find exactly how the lead in the air is impacting our community because we don't have the community trust or have the funding or have the expertise to do hair samples, right? Not all communities are going to be open to that, and nor should they based on their history, which is why it's so important to do what I talked about in the first few slides and looking at community history and community context to know where those limits are. We were doing an HIA in Puerto Rico 4 years ago around Zika uptake of vaccinations. And we were talking with the people at the institute there at the university, and they said, you can't ask people to get the vaccine. You can ask them, have they, and why or why not, but you can't tell them that this is what they should do, because they have such a distrust born of their history with the US government of experimentation. So making sure that you understand those contextual limitations and that you're very clear about them. I'm not saying that you need to put in your HIA that the people of Puerto Rico don't trust the US government, because that's not true in all cases. What you need to put in there is, we did not do biometric testing for these reasons. Whenever you get to, you've got your data, you've got your qualitative and your quantitative data, and you want to start interpreting those findings, make sure that you're doing this with the community, that you are working also with decision makers and stakeholders. A lot of times we talk about working with the community and getting their input, but we don't talk a great deal about working with the people who are going to be making the decision and the people who are going to be implementing the decision. And whether that is the technologist at the local or state or federal government, the people who oversee programs, or whether these are field personnel who implement programs on the ground and talk to communities every day. We need to make sure that all of these voices are included, because we don't talk about it a lot when we're teaching HIA to new folks. We talk about community voice, but we also want to be sure that the implementers are at that table, because you can find all of these great findings and recommendations with the community. And if they're not feasible, if you are not managing people's expectations to the possible, then you're not going to have a process that feels inclusive and feels impactful to anyone, not just the community. And making sure that you're also thinking about additional findings as they come to light in your community engagement and your process, right? Because things that seem very clear when you're doing your analysis at your desk might not be so clear whenever you're talking with the community. So you will have to adjust your thinking and adjust what you find based on the interpretation of the findings, right? Based on how these things are perceived. So in your findings section, you want to make sure that you've characterized the health impacts according to the parameters. And these are the ones that we want to make sure are included. There are other parameters, but if you have included these, the direction, likelihood, magnitude, and severity of the impacts, and their distribution across the population that's impacted, then we feel like, because this is what's in the minimum elements and practice standards, right? These are the things that if you are taking care of these issues, then the other things will follow, and you'll see what I mean. So this is a chart. Some of you may have seen this before. I've shared it before. And how I think about those factors, right? Likelihood means, is it possible? Is it likely that these impacts are going to occur, right? So the direction is plus or minus, and that's the magnitude. Is it going to be severe, moderate, maybe negligible, small, or is it no impact, right? So your magnitude really says, how bad is this going to be? Severity is how can it be handled, right? Can it be triaged? Can these impacts be mitigated through the recommendations? Or are these impacts going to be irreversible over time? And then making sure that you're also tuned into who is especially vulnerable to these impacts and their distribution across the community. So is it just elders? Is it just small children? Is it maybe people who work outside, right? If you're thinking about heat impacts. So making sure that you're capturing not just who we in public health normally think of as a vulnerable population, but maybe they're socially vulnerable populations. Maybe there are physically vulnerable populations that we wouldn't ordinarily consider. So thinking about who is impacted. And this is just a different way. I know that we all learn differently. And so this is the graphical, right, depiction of those findings. And making sure that we are looking at all 5 of these things as we are working with our community. Impact tables are another tool that we use to communicate with the community whenever you have your health impact. This is one of adding a fast food restaurant, and you can see that the HIA found that it would negatively impact people's health in a low resource neighborhood because they wouldn't have other options for quick food, that it would be high because there wasn't a grocery store in this community. The severity would be high, that it would impact lots of people over time in a severe way. Very likely that this would happen, and that it would impact lower income residents more than people who have different choices, who can maybe leave their neighborhood to find groceries. This is another example of an impact table. This is looking at emissions from a Complete Streets project, and thinking about, you know, some of the strategies around safety and traffic calming and some of the different impacts over time. This is just a different way of displaying the same type of data. And thinking about what needs to be documented in your HIA. What do you need to be super explicit about? What do you need to be clear about is your assumptions, the strength and limitation of your data and your methodology. Making sure that if you have brought to light data gaps or gaps in being able to assess something, maybe the indicators aren't at the correct level of granularity. I talked about, you know, census tract level versus citywide level versus neighborhood level, right? What are those data gaps that need to be filled before you could do a more robust, or the next person who comes along and works in this community could do a more robust analysis. This is also where you should show possible impacts that you might not have had data to validate, or things that the community brought up, or that you just don't have sufficient strength of evidence to make a recommendation for. Remember, I talked about in the beginning, we're never going to have perfect data. We're always going to have uncertainty. What you need to do is just say that, right? It's perfectly fine in an HIA to talk about these levels of uncertainty and how you try to mitigate them, because that's really what's important. And then your findings as interpreted with the community really should be what drives your recommendations, which is what our next webinar in the HIA How-To series is about, is forming these recommendations. If there are recommendations that come from the community that don't have evidence to support them, you need to go back to your evidence and you need to say, this is validated through community narrative. And go back to your community and say, are these things you want included? We don't have scientific evidence, but what we have is your community knowledge. Do you want these in here? And you just say that, right? And we made these recommendations with our community because these things are important to them. That's what you need to put in your HIA. Just because you don't have 42 scientific studies, that say this is the answer, doesn't mean you can't put forward that answer. We're never going to have perfect data or perfect certainty. This is public health. Humans are messy, right? But if you haven't co-created your recommendations based on your data and your community narrative, and you haven't done this with your community, then your HIA is not going to be seen as valid. It's not going to be accepted, and you will not have community as your advocate for the solutions. And an HIA that's just been done, by a researcher who doesn't live in the community, sitting at their desk, is not as powerful as one that's worked with the community and have those community-driven decisions. So this is the end of my formal presentation. I wanted to leave some time for questions, but I also wanted to give a plug for, again, joining SOPHIA and for our next upcoming webinars. The next one in this HIA how-to series is going to be on August 10th. And I will see you at the same bat time and bat place for that one. But I'm really excited that in September, we're going to be, we'll have Christine Ortiz-Gumina from the National Network of Public Health Institutes to talk about the using health and all policies approach for public health preparedness. There's a tool that's out that Christine and I co-wrote for the National Environmental Health Association, and we'll be previewing that tool for Public Health Preparedness Month in September. And then in October, we're going to have Dr. Ben Pauly from Kettering University, who's going to talk about his experience in Flint of using community narrative to drive health decisions and integrate community narrative. So I hopefully have stopped sharing. And I will turn my camera back on so I can see you. There you all are.
So there's one question in the chat that Jimmy wrote. He asked if you could talk a little more about adapting to where different sectors might be on the journey to equalizing qualitative and quantitative data. Public health is doing all of this in the space. Jimmy, you can add on.
Thanks. Yeah, and thanks for that, Sandra. It's always good for a refresher on these things. And I was doing a bunch of things, so you may have touched on this a little bit, because from where I sit in public health and do a lot of maternal health equity work, it seems there's a lot of energy in that silo within the public health sector to really acknowledge that parity between, the objective quantitative data and the qualitative community story type of data, and are getting comfortable with that. And I think other parts of public health are doing that. And I'm curious, from your experience or others on the call here, how do you observe that unfolding in other sectors? Like, are transportation engineers starting to think differently about it? Are they still only going to be driven by dollars and metrics? Are folks in the education policy making space, are they more or less open to this? I'm just kind of curious where different sectors we might want to collaborate with are on that scale from people's observation.
Well, I'll just speak to my experience first, and then I'll open it up if other folks want to chime in. I don't know that we're going to convince engineers that community narrative is valid science at this point in time. I think that it's becoming more and more acceptable. It's becoming more and more crucial, especially in the planning space, right? Like I'm a planner. And so for me in the urban planning space, we have to go to the community, right? It's required, it's in our DNA of working with communities, but that's not true of other parts of the profession. I think that public health in maybe not in the maternal and child space, right? It sounds like they're coming along, but in the community planning or the community assessment space, right? We're very open to working with community and having community narrative validated, but I'm not sure that we're there in other pieces of public health, right? In the planning space, I think planners are very open. I think that transportation planners are getting there, but I also think that we have a long way to go in agriculture. We have a long way to go in even brownfields redevelopment, right? In having that community narrative as acceptable. But I'd love to hear what other folks, what their experience is. You can, at this point, if you just want to unmute yourself. Oh. I'm wondering too, if other people are in your work, in your daily work, where you might not have done an HIA yet, have what kind of other spaces are you using community narrative? I'm really interested in this idea of using community narrative to drive other kinds of decisions. In my work with the EPA, we are working on developing a framework for cumulative impact assessment using HIA as a framework, and really like talking to people in the Office of Air, the Office of Water, right? They're like, why would we want to talk to the people in the community? We don't like, what would we do with that information? And so I'm just kind of curious if other people are doing this, looking at this right now. Well, that tells me that I am working on the right things that the field needs, right, and is interested in.
Sandra, do you see this chat from Kelly?
I do, thanks, Oma. We have a question from Kelly. She wants to know suggestions for developing an HIA, on controversial transportation project underway for years. Yeah, I think you're right. I think the HIA data would be contested. Do you want to talk a little bit, tell us a little more background, Kelly? I know that I'm working on a project in Tacoma, Washington, and one of the interesting pieces of it is we are taking the EIS, right, and saying, and human health in each of the sections. But I'm curious about the project that you're working on that brought this question to mind.
Sure. It's not yet an active project. It may be. So the HIA is a little bit of an afterthought, or it's being advocates are asking for an HIA. So it is, I think they are hoping to be able to use it as a political tool. It's a project where it's a lot of elected officials are supportive of it, but environmental groups and some environmental justice groups are against it. It's driven by a state DOT that has not been great about authentic community engagement. And I don't know if it's going to have much budget that it would enable substantive community engagement as part of the HIA, because I think they feel that they've done that already. And so I suspect that if it occurs, it would occur as a kind of a technical exercise. And so I wonder if it's a little bit dead in the water, if that's the approach.
Yeah, that is an issue, right? That people do these things as afterthoughts. I can't tell you the number of projects where I've been brought on to do an HIA, and I'm like, but you've already made this decision, right? Like you're way down the road, and HIA would have been useful 6 months ago, right? And especially building it into a transportation project and the initial, you know, like if you were planning this project, I know you would have built this in from the beginning. But whenever you're coming at it after the fact, I think that the best way that you can use community narrative is really to, in a controversial decision like this, is really to validate the science in some ways, right? To validate what the community wants and to reinforce that. Because, you know, it's not, I see all the time, especially in transportation projects, oh, well, we did an EIS, we checked that box. Because in the EIS or in the NEPA or the SEPA legislation, you know, it says and human health. Well, we did that, right? Like we looked at the amount of fresh water that would be impacted. And so we took care of the humans. Excuse me. When in fact, what you really need to do is you really need to drill down into an HIA so that you're making sure that you're getting all of the health impacts, because an EIA doesn't necessarily care about the people part of it. And that's why I think that it's just so hard to get people to buy into HIA after the fact. But I'd be happy to talk with you some more offline if you want to explore that some more.
Yeah, thank you.
Other thoughts, questions, comments? Well, I see that we are almost at time. So I want to thank you all for tuning in today and to the rest of the series. If you missed the first 2 webinars in this series, you can find them on Sophia's YouTube page. And I hope to see you at our next webinar next month. Thank you for coming.
Thanks, Sandra.
Bye, Jimmy.